Away.
Hello, everyone. Welcome. Good evening. My name's Twyla McGinnis. I'm a registered nurse and a nurse administrator, and I'm passionate about primary care. I'm a member of Primary Care for All Americans, serving as a board member and on the steering committee. And I want to thank you for joining us and 800 people in 40 states and DC and 322 zip codes who are building this movement together. The crisis in primary care is real. I live primary care every day. And most recently, I know it in my own family from my son who injured his back and is not able to see a primary care provider until next January. I hear it from friends, family, colleagues, all being worn down by the business of medicine. They're tired and dispirited with little to no hope until primary care for all Americans came along. I've listened to high level bureaucrats, politicians, financial people in healthcare for 40 years. I know as well as anyone, there is no one in charge, and the cavalry is not coming. There is no one to fix this but us. And I'm thrilled tonight we're going to hear from Ted Long, Senior Vice President, Ambulatory Care and Population Health, and a primary care physician for New York City Health and Hospitals. And please stay on at the end when our board joins Ted for questions and discussion. We'll be talking about how you can bring primary care to everyone in your own neighborhood and community. It's now my great pleasure to introduce our moderator for this evening and to thank the Zoom committee for PC4AA, which organized this Zoom, John Wright and Brian Kaiser, who's also our MC tonight, and Patty Armstrong, our ACE Zoom producers, and all of our presenters. Take it away, Brian.
Thanks, Twyla. Hi, everyone. I'm Brian Kaiser, and I want to thank you all for coming tonight. Being here makes you part of this movement as we together learn the tools we need to provide healthcare for people, not for profit, in every neighborhood and community. Please take a second and tell us where you're from in the chat if you haven't already. That way everyone can see who we all are as we work together to build this movement. To make this movement rock and roll, we've implemented our new policy on culture, tolerance, and respect as we work together to create a welcoming environment where everyone can contribute their unique talents and ideas equally. So, no professional titles, please. Let's talk about the importance of being here together, engage in this work, and the value of those ideas and commitments, which are what will build this movement at the end of the day. It's my pleasure to introduce tonight's speaker. Ted Long is the Senior Vice President of Ambulatory Care and Population Health and a primary care physician at New York City Health and Hospitals, which has nearly 6 million ambulatory care visits annually and has one of the nation's largest federally qualified health centers. He supervises NYC Care, a universal access program for 140,000 New Yorkers, and leads operations for NYC's humanitarian centers and arrival center for asylum seekers coming into New York City. 145,000 New Yorkers. Wow, that's almost as many people as live in Providence, Rhode Island. So for tonight, we're here to both teach and learn from each other. We encourage you to ask questions, put them into the chat, and we'll have time at the end to answer as many as possible after we hear from our keynote speaker. We'll try to end the formal program right at 9 p.m. Eastern, 6 p.m. Pacific time, but we invite everyone to stay for an interactive half hour at the end as we work together to discuss plot and plan. Now, I am very pleased to introduce our keynote speaker, Ted Long.
Thank you so much for having me tonight. It's a privilege and honor to be with you all. It's especially a privilege and honor as I've known Dr. Fine for almost 10 years now, and I know that there is no more dedicated or committed person to expanding primary care to every American in the country than Dr. Fine. So I wanted tonight to talk a little bit about our experience in New York City and share with you a model that we developed here that I hope might be helpful as other cities and states contemplate what could be done to treat primary care as the front door to the human right of healthcare that it is in our country. So I'll take you back to 2017, 2018 now. In 2017, 2018, New York City Health and Hospitals, the largest city-run public healthcare system in the country, was in trouble. we were not only losing $1.8 billion a year, which even in New York City terms is a lot of money, but worse than that, we were losing thousands of patients every year. Now, in our healthcare system, New York City Health and Hospitals, it's always been our mission to treat healthcare as a human right. But a typical experience was if somebody was calling us to make a new patient appointment in primary care, they would call, they would say, "Can I make an appointment?" We would say, "Of course, we would love to see you." They'd say, "Great, when?" We'd say, "In a few months, maybe longer." Our wait times were, our third next available was approaching a month. Our wait times were getting longer and longer, and more people were deciding not to come into our system. So I knew when I entered our system that we had one of the most important problems in the world to solve. We needed to save the day, not just save the day financially, but save the day through bringing the patients back to our system that had either been with us before or trying to engage to find their long-term primary care doctor going forward. So I knew the first thing that I needed to do in our system in New York City was we needed to fix access to care. It's not treating primary care as the front door to the human right of healthcare if you can't get in the front door. So we initially made a series of changes. We looked at our primary care teams. I have Dr. Andy Saul on my screen here, and he did not know I was going to call him out, but he said something to me that really stuck with me a long time ago in Rhode Island. I asked him what the number one thing we needed to do to fix primary care was, and he said five things: workforce, 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 workforce. And that really stuck with me because in Rhode Island, that turned out to be the case when we studied it. And it certainly was the case in New York City, too. So we put out a campaign called Docs for NYC. We attempted to bring as many primary care doctors into our system as we could. We also looked at our care teams. I can hold my own titrating insulin, but I'll never be as good as our clinical pharmacists, nor will I ever have the access that they have. They could see my patients every day if they want to, but we had a grand total of zero clinical pharmacists in our whole public healthcare system treating more than 1 million people every year. Zero clinical pharmacists. So we did, and we also weren't we weren't in open access at that time. So we scheduled appointments 3 months out. More than one out of every five people didn't come to their appointments. So we had a system that really was just begging to be fixed. So we started to go to open access. We expanded our care teams. We again aggressively recruited doctors, and we started to see it working. So from when I started at the end of 2017, early 2018, a year or two in, we saw our third next available, an imperfect measure as it is, but it's a measure we have for looking at access, cut in half. We saw our care teams expanding, we saw our panels being filled, and we saw people starting to actually come back to us, for primary care. It was at that time where I realized that we had another very serious challenge, and there was a unique opportunity we had, and that's the program I want to tell you about today. We couldn't have done this before we fixed access. Now, I want to be very clear on that point. You can't go into a broken system and attempt to bring 100,000 more people in and expect it to go well. We had to make these fundamental foundational fixes first to improve our system to, again, treat healthcare as the human right that it is for all New Yorkers and all Americans. But once we started to make progress, we were able to start a program called NYC Care. This program really addressed the fact that before the program, even people with insurance had trouble getting into our system or in a variety of places in New York and elsewhere. But for undocumented immigrants and people that made a little bit too much to qualify for Medicaid, but not enough to actually afford a healthcare insurance plan, a huge population of people in those two groups were slipping through the cracks. So what we did is, again, once we addressed access, we started this program. We had funding that went to advertisements. We had funding that went to having community-based organizations go into the communities and say, "It's a new day today. You can actually make an appointment to be seen," which is different than your experience in the last, several years, potentially several decades. I'll never forget the first patient that I saw in my practice in the Bronx, my first NYC Care patient, a matter of weeks after we started the program for the first time. There's a woman that came to my office. I saw her. She didn't know if she had diabetes, had never had a mammogram, never had a pap smear, didn't know if she had any other healthcare issues. So we got through everything. I explained to her what healthcare is. I explained to her what vaccines are, explained to her about the mammogram I was ordering. I gave her everything to bring her up to date and to keep her healthy. But at the end of my visit with her, I couldn't help but ask, why today? What was different about today? She shared with me that she hadn't seen a doctor in 43 years. That's why she hadn't ever received any preventive services, didn't know if she had any chronic diseases. And her response to when I said, "Why today?" she started crying. It still gets me. She said that before that day that I saw her, she didn't believe that she deserved healthcare. And I started crying at the visit too. Um, but that all it really stuck with me, and I always think about her. She's in the front of my mind whenever I think about the importance of our program, because she didn't believe that in New York City healthcare was a human right. And even though we that was our mission before we fixed access, we weren't delivering on that mission when the front door to primary care, or the front door of primary care to the system was locked or you couldn't get in. She got in that day. She saw me. She got all the care that she needed and deserved. And then she went and told her family. She told her friends. And many other people had the same experience. So we catapulted from a program of literally one to now more than 145,000 New Yorkers, all of which are either undocumented immigrants or people that make a little bit too much to qualify for Medicaid, but not enough to actually qualify for, or not enough to actually be able to afford a health insurance plan. But the thing that unites all those 145,000 New Yorkers is they've all had the same experience that my patient had. They've all felt like they've had barriers before them that prevented them from getting healthcare, which is their human right. But now we've torn down those barriers and we can celebrate 145,000 people that'll celebrate their birthdays knowing that they have a chronic disease, knowing that they've gotten all the vaccines that they deserve, and knowing that they've gotten the preventive healthcare that they deserve as well. So in New York City, we've made this small change to make this program. It has had a huge effect on so many different people. And I think one of the ways that I think about it, and I hope this is something that we could talk about more during our time together today, is that this is really a transportable program. All we've done is funded primary care as everywhere should. But through funding primary care, we've seen a colossal effect, not only in people being able to access their human right of healthcare, but we've seen a significant improvement in A1C control and blood pressure control, variety of other measures as well. So we've done something that I think could be done in many other places, and I'd love to answer your questions and share more about how you can learn from what New York City did to be able to potentially have this program everywhere.
Thank you, Ted. Do you have a question for Ted? Please post it in the chat. Together, we can make sure that everyone in the United States receives equitable health care and gets equitable health, regardless of where you live, how much you earn, what community you come from, or what you look like.
Hi, everyone. I'm Patty, and I'm part of the PC4AA team, and I am going to be fielding some questions. So drop them in the chat as you see them, and we're going to get started on a few. You ready, Ted?
Definitely.
Are you ready? Okay, so I've heard this number a few times. I'm going to say it out loud myself, which is 145,000 people getting primary care. How many lack health insurance are undocumented, and how many languages does this population speak?
Yeah, great question. So NYC Care is here to help every New Yorker, and New York City is a diverse place. Our NYC Care members speak hundreds of languages, and I have one patient that I think about a lot, who when she comes into my office when to see me, she always has a big smile wrapped around her face because she speaks an uncommon or rare African dialect, and I'm literally one of the only two people she can talk to when we get an interpreter on the phone. So we're proud to have a very diverse program that helps anybody that comes through our door. In terms of the bulk of our 145,000 members are undocumented immigrants, that most of which, of course, have been in New York City for a long time, like my patient that hadn't seen a doctor in 43 years. But for a variety of reasons, a variety of barriers perceived and real that they've had, they haven't been able to access healthcare to date. This program changes that for them. We do have some number of people too that, again, slip through the insurance crack, where again you make a little bit too much to qualify for Medicaid, but not enough to afford an actual insurance plan. Regardless of what your reasons are or what your situation is, we're here to help you. And therefore, we enroll everybody in NYC Care that doesn't qualify or can't afford insurance.
Okay. And then in terms of the workforce that it takes, how are you finding these people, and about how many of them are there? Like
Yeah.
of the workforce.
And actually, if I may, I see, sorry, I'm not very good at multitasking, but I see Fred Harrington asked a really good question here. What type of marketing, if any, is necessary to acquire these patients? This is one thing I've learned, and it's a lesson I've really taken to heart. is that I think we've all the primary care doctors in this call know that we all try our very best to move heaven and earth within the four walls of our office. But often it takes us to go beyond the four walls of our office to meet a lot of patients where they are. So it really is, I've really appreciate the importance of having our community-based organizations be our trusted messengers to go into the communities that they're from as well, that they speak the same languages of and that they look like, to be able to tell people, hey, there's a new day at New York City Health and Hospitals. Again, you might not have been able to get in when you called last year, but today you can get in. And what the cornerstone of that, which I told all of our community-based organizations as well, and we've delivered on, I know the numbers here, 97% of the time, is that we guarantee that we offer a primary care appointment for every new patient within 2 weeks. So if Dr. Fine calls today, we guarantee, and we've succeeded 97% of the time, that we'll offer Dr. Fine an appointment within 2 weeks of when he calls.
Wow, that's very impressive. When we talk about that workforce, then again, going back to this idea of, so how many doctors do you have to actually, or primary care providers to actually make that happen?
So that's a great question. It gets back to one of the things we had to do before we started the program. We've expanded our panel sizes to be able to help everybody that comes to our front door. So today, our panel sizes for a full-time primary care doctor, our panel size is 1750. But it's not just 1750 for the doctor that's on their own. It's 1750 with the full complement of the staff that we've built out more and more over the past 7 years. For example, we have clinical pharmacists in all of our practices. We have programs that are nurse-led that we call our treat to target programs in all of our practices for diabetes, for high blood pressure. We have a collaborative care model for social work. My mom's a social worker. I'm a big fan of social work. We'll never have enough psychiatrists to address the mental health crisis in our country. But if we bring social workers to help us, we can succeed in delivering mental health to everybody. So it's a model where a psychiatrist will oversee a team of social workers that will be delivering the direct care. We've studied it. It's very effective. We also have built out a community health worker program that helps me to know that when a patient leaves the four walls of my office, if their barriers or risks are social risks, I know that I can assign a community health worker to them. We have 250 community health workers in our system today. I think that puts us among one of the larger programs, but we're very, very proud to have made that investment because there's no other way that we can know and have the certainty that I don't have to worry and call my patients to see if they were able to do X, Y, or Z to support their family. I know my community health worker will do a better job following up with them.
No, I think that's so important, is that layered approach. That might not be the right terminology, but that multi-layered approach with that. Now you're talking about a lot of people, a lot of training. I've seen a few people post in here about funding, right? And that training part. What's your secret sauce?
Yeah, so I'll tell you how we do it again, how we did it in New York City. With my hope in telling you this is that there might be pieces of what I say that may help you to go to your potential funders and see if there's an opportunity to do something potentially similar. So New York City has chosen, and I'm proud of this choice, to invest about $100 million a year into the NYC Care program. That money goes to in a couple of different ways. It funds the primary care that we provide in the front lines. It also funds marketing, advertising, in our community-based organizations as well. Going back to the excellent question earlier about that, I think that's an important lesson learned, is that if you just build a program but don't tell people in the right way through trusted messengers, you might not have the reach to reach everybody that really needs to come and see you. That's also given us a lot of great feedback too. I not only listen to my patients in terms of how we've designed the program, but we listen to our community-based organizations and our community leaders as well. For example, early on, it seemed important, that was from feedback that we received, to give people a card to show them that they belong to a program. But what do you put on the card? I actually asked my patients what they'd want to see on the card. And we asked our community-based organizations what they would want to see on the card. So what we have on the card, which we started back then, is true today, is you go through financial screening to enroll in the program. We have your individualized fee scale for any service you'd want printed on the card, so there won't be a barrier of you not knowing how much you might have to contribute. to get a medication to see me in primary care or even have to go to the emergency departments. So most people, the fee scale is 0, but for many it's $2 for medication. But still, we want to make sure that people know and feel comfortable knowing exactly what the cost of care is and have it be completely transparent. And it can't be more transparent than a card that you literally keep in your wallet.
That sounds awesome. I hate trying to figure out how much my meds are going to cost. Like,
Everybody
the
does.
doctor, oh, it's like the one of my top pet peeves with all of this. So you mentioned the New York City scholarships and all of this. So when we look at, and you've mentioned this idea of, you know, a copy paste in another city, how, like, are there cities that you think are primed to do this? Are you like, oh, you know, we think this state or this city should be the next on the list to go?
I have no idea, but what I can tell you is from everybody from all those cities that might want to do something like this, use me and anybody from our New York City team as a resource. We'd love to help in any way that we can. Again, based on however our experience can be helpful.
Awesome. Well, I know that there are a lot more questions in the chat. We will try and loop back to them in just a quick minute, but Ted, thank you so much for, you know, having this conversation with us and being open to supporting others on their journey to provide primary care to all Americans and all of your insights. So thank you so much. Michael?
So, well, it's an honor to be here.
You're on mute, Michael.
Thank you, Patty, but thank you, Ted. Thank you, everybody. I'm never going to forget this talk for lots of reasons. 145,000 people, 250 community health workers, and that one woman who hadn't had primary care, hadn't had any medical care for 43 years. In 1977, I actually was working in the South Bronx and got to train some of the first, what we call local health workers, the first community health workers in the United States. And to hear that work come around in this way has particular meaning for me. This is really exciting stuff. And I hope it's sparking ideas in every one of us about what we can do to bring primary care to everyone in each of our own communities. Remember that primary care for all Americans needs you to start local and state work groups, needs you to join our social media and development work groups, needs you to help connect us to community and family foundations and people who you know make end of the year charitable contributions and even begin to make small monthly charitable contributions to primary care for all Americans so we can sustain our work. Remember, if we don't step up together, we get stepped on. Healthcare impacts all of us, but when we work together, there isn't anything we can't do. So please reach out to colleagues, family and friends. Please make sure everybody gets out to vote, and then make sure everybody joins Primary Care for All Americans and helps us build this movement together. And you know my thing at the end, this isn't a Republican thing. This isn't a Democratic thing. This is really an American thing. We all need great healthcare in our communities. Ted just showed us it can be done. We're the public in public health, and the time is now.
Thank you, Michael. We encourage everyone to bring someone to our next Break the Stranglehold Zoom meeting on October 29th. We will be breaking into work groups and rolling up our sleeves together. You will not want to miss it. Please register on our website, primarycareforallamericans.org. And while you're there, please click donate to support our work. Together with a regular monthly contribution, please give what you can. Every little bit helps. We need and appreciate every single one of you for helping to spread this movement across our nation to get the change we need and that you deserve. Healthcare for people, not for profit. That's primary care for all Americans.
We are so glad that you all are here with us tonight. We are going to continue this discussion for at least a little while longer as people are available. If you want to continue to ask some questions in the chat, and we will have board members joining us for some discussion. I think we're going to roll out of the formal recording of this, or do we keep going?
We're going to keep
Michael,
we're going to
we're
keep
going to keep
recording.
recording. Okay, so as people need to go, we understand, but we do want to come back and hit some of these great questions that were up here. Let's look. Ted, did you see anything that really stood out to you? I know you were scrolling through while we were chatting before. Not calling you out.
Too many great questions. Didn't know where to start.
I think one that I see popping up a lot is can you explain to me the difference between what you're doing and how you would work with like a community health center?
Oh, that's a great question. So when we started the program, it was most feasible to start it within our healthcare system. We, again, are a fairly large place. We have 11 hospitals, a large FQHC with 30 sites. That's our ambulatory care portfolio. Overall, we help about 1.1 million New Yorkers a year. In my AmCare system, we help about 450,000 New Yorkers a year that are unique to our primary care in our system. So we started there, but we worked with the other FQHCs in New York City to help with specialty access. So we're all the world's on Epic, um, and we had a series of meetings and trainings to have other FQHCs that might be serving patients, or patients that we might share, to be able to do specialty referrals to our hospital sites through Epic Care Link. But I think as you're structuring a program like this, there's many different ways to do it. LA a long time ago did a similar program under Mitch Katz, my boss. And there, I believe they took an approach of starting across the board with all of the FQHCs. So I think it's there's different ways to do it. I don't view in my view there's no wrong way as long as you are investing in primary care and getting people access to primary care.
Absolutely. And the next question that I see, I think sort of fits into this, which is, how long are you allotting for a patient visit or a follow-up appointment within your structure?
So in our system, about 85% of primary care appointments are revisits. Those before I came were 20 minutes and today are 20 minutes. For new patients, we've gone back and forth on this a bit. So our new patient appointment length had been 40 minutes. We are currently changing that to 20 minutes because the success of our program has given us a good problem to solve, not only NYC Care members, but also other insured New Yorkers are calling to make appointments with us, but we've run out of access. We've now have a wait list of tens of thousands of New Yorkers that we are doing a series of changes. The appointment length is just but one of them. We're expanding our care team strategically, going to open access. We can actually even measure using data the day that's most likely for a new patient to actually come to their appointment, so to time release the slots. By the way, it's 10 days. So in doing all of that, we're hoping to be able to create enough access to be able to help every New Yorker that's calling us. But again, a good problem to have that so many people now want to come to us for primary care.
Absolutely. And I think one of the challenges, and I'm seeing this in one of the questions, so if I'm not doing the question justice, I apologize, which is, as you grow and systems come into place, how are you holding to? I loved when you said appointments were 20 minutes when I started and they're 20 minutes now. Like, what guardrails have you put into place so that you don't start seeing that like 1 year they're 20 and then a couple years later, oh, they're 15 and now they're 10, right? And that creep that can sort of happen.
Yeah, that's a great question. I'll get started on the answer, and if the whoever asked that wants to drill down further, very happy to. I mean, I think that's in our system. It's one of the advantages of having our leadership be doctors like me that practice and see patients. I see patients every Friday in the Bronx. I have a good sense of how long it takes me to feel like I'm able to deliver healthcare in the form of a human right that it is to my patients. And my boss, our CEO, Mitch Katz, practices every Wednesday in the Lower East Side of Manhattan. So for us in our system, that's a very different approach than we've taken before. It used to be, I don't know if we had doctors in leadership roles in the past, but between Mitch and me now, it's everything we think about is how can any change that we want to have help the patient in front of us or help the patient that could be in front of us or that wants to be in front of us, our future patient. So I think that's made a big difference for us.
That's great. Scott, you had a question about data and the utilization of it. Would you be available to come ask or make sure we word this question correctly? I had a new message pop in. Maybe not. I have a tendency to call on people right as they're putting a bite of dinner in their mouths. So let's look at some other questions that we have here.
Paul had some good questions. I wonder
Oh,
if
yeah.
Paul would speak up.
Yeah, Paul, do you have a question that you would like to ask directly? Because you had a few that popped in there quite nicely. It's just finding that unmute button. It's tricky. It keeps hiding. Nope, you're still muted, Paul. Nope,
Not working.
he doesn't want to ask any more questions. If you do find that unmute button, let us know. Pat, did you have a question to ask? You had a few pop in there as well. Pat's gonna have to.
Where's
there
my
you are.
unmute button, Pam?
There it is. You found it.
No, Ted, thank you so much. This has been inspiring, as Michael said, and it gives us all hope. We're trying to extract out from this very quick glimpse of something that's taken your lifetime to do. And we appreciate that, how we can extract out some key elements and teach these to other people to take some of this hard-earned education and apply it in their own local community. And I think that's where we'll come back to you and have you help us put some of this wisdom into our playbook so that everybody around the country can, at least get some of your ideas and then get a link and start emailing you. You have 145,000 patients now, but we're going to have 145,000 communities contacting you to try to get the information that's appropriate for their community.
Let's hope so.
So, Sarah, did you have some specific questions that you wanted Ted to help us with on this endeavor?
Ted, this was so amazing. And I'm so proud of the work that you're doing. Thank you so much for sharing that with us. So I'm one of the co-chairs of the playbooks that we are using to help states and communities at the work group level figure out how to do something similar to what you've done, but for their, applicable to their own communities and their own states. And so I just would love to connect with you offline to get some help and some insights. We've already deployed our state playbook, and now we're working on the community or local level state book. And you have so much wonderful insight there. So, and I'm sure the battle scars to prove it. So we would love to get your reactions to, what we've already included in the playbook, and just like a very direct feedback about, no, scrap this, you need to add this, redirect that area, because you know what you're doing.
I would love to. That'd be an honor. You were right. I gave you the quick and smoother version.
Yeah.
Ted,
I know
can I?
it's a hard-won success, and so yeah, I just really honor that.
For sure. Ted, can I throw in a question?
Yeah.
New York provides $100 million a year to run this system, which is fantastic. And it's kind of funny because some of us have argued that Rhode Island, which is only 1/8 the size of New York, ought to be spending $100 million a year on primary care. That said, I think the real or one of the real challenges besides workforce is getting municipalities and states to directly invest that kind of money to provide primary care. There's New York, there's LA, I'm not sure where else there is Situate, Rhode Island, just saying. But I'm not sure where else there are places around the country that are making that kind of direct investment. First, do you know of anybody? And second, if you were somebody in Arizona or in Arkansas, and we're going to approach a city or town or a state to do this, what would you say?
That's a great question. I'll share because I have more knowledge about this, and if anybody from San Francisco is on, of course, correct me. But San Francisco and LA had precursor programs led by, again, my boss, Mitch. And we took many pages out of those books as we constructed what we thought would be meaningful in New York City, or what we thought would also be feasible. I certainly can't speak for Massachusetts, although I hear that you're doing some potentially exciting work there. Um, what I would say is, again, in my view, healthcare is a human right, and I take that really seriously. And if you don't let somebody in the front door of primary care, you're not treating healthcare as a human right, and there's just no other way around that. And the $100 million investment is how we fuel our primary care services and bring people into our system. That doesn't cover emergency department use. It doesn't cover inpatient days. But then those are costs that you're going to pay anyways. And if you do nothing different today and you go to work tomorrow, this person that was going to be admitted tomorrow will still be admitted. But if you fund primary care, you not only stand a chance of being able to avoid their admission in the future, but that's where we apply the funding to. So we don't have to use the $100 million to cover inpatient stays. That would um, the money would go a lot faster that way. But if we use it just to fund primary care and assume that the other costs are things that would happen anyways, but maybe we can actually chip off of them by delivering good, high quality primary care to all, then we're making the system and the city a better and maybe even financially healthier place. But we're focusing our investment where it needs to start, and that's primary care. And we've been very clear and explicit about that. And I think that's such a key and important point, is not to boil the ocean overnight, but starting with primary care and funding it appropriately.
Thank you.
Right. Well, while you guys think and add some more questions, and one question I have for you, Ted, and this is a little bit self-serving, knowing our social media team will be meeting at our next meeting, which is, what were some of those key educational things that the user needed to know, like about primary care, or what were some of those sort of low hurdles that your marketing team utilized to get people to engage with primary care?
Mm-hmm. So we needed to build trust, and that started with, and this may be a New York City specific thing, and it's going to sound overly simplistic, but it is real. We needed to start with explaining what primary care is. The best messenger for that are our community-based organizations that, again, know everybody in their communities. And if we arm them with the right things to say, and they appreciate it as well, that's worth its weight in gold, and being able to go out there and build trust among community members to come into primary care in our system. So that was step one. And then in terms of other sort of lessons learned and what we want to communicate, from a marketing point of view, we put our logo up with a simple to remember number in bus stops, on buses, in places where people live, play, congregate. I know it sounds simple too, but the number is important. Our number, I'm going to tell it to you right now, and everybody on this call will never forget it. 646 NYC Care. Pretty happy it was available. But things like that go a long way. And then I think also, in terms of how we articulated the program, but how people also explained it to friends and family members, don't underestimate the barrier that not having financial transparency causes. So many people don't come for care because they, like probably half of us on the call, don't know what their medications actually are going to cost them, don't know how it's actually going to hit their wallet, and feel like they have to make trade-offs about supporting their family by paying for their apartment or getting that medication they heard about for diabetes. We want to make it real simple and that's a false choice. Nobody should choose between their apartment and their chronic disease. but that's what people at least perceived that that was a barrier in front of them. So breaking it down, putting that dollar amount that's specific to them, that, looking at Dr. Fine again here, Dr. Fine gets his card and says, this is my specific copay, or rather fee scale for any medication that I would need to potentially save my life. It's right there on the card. There's never any deviation from that. Something you know and trust.
I think that's a really, really important thing. Paul, looks like you're back here and you found that mute button.
I did. Thanks for letting me ask a question. So I used to be a primary care doc, and we had good access in a whole bunch of large independent medical groups. Today, they've all been swallowed by some kind of corporate entity, either the local hospital or a larger entity. And I'm watching access go to hell. I used to have 1 or 2 day access, and now it's 12 weeks. The question is, how in the world can we get this expanded out into the for-profit world where bad primary care seems to help the profits by having more sick people?
You're cutting off. I think you might be going to mute.
No, I ended with
There we go.
what I had to say there.
Got it.
I'm
And
watching Michael Fine nod his head up and down.
that's a terrific question. But I'd be happy to follow up with you offline about this too. The way that we found success in, I would say, amplifying the effect of the NYC Care program was by also embracing value-based care and our insurance at-risk arrangements. So when somebody wants to come to us for care today, Paul, let's say you come tomorrow. We're going to financially screen you as part of the process for getting you to see me as your new doctor. If you're eligible for health insurance, we want to enroll you in health insurance. And we in our system actually own a health insurance plan. For any New Yorkers, Metro Plus is a plan that we completely own. We also are partial owners of Health First, another large Medicaid managed care plan in New York City. So when people are coming to us for care, if they are eligible for insurance, and many, many people don't know if they're eligible for insurance, we'll preferentially encourage you to enroll in health insurance. And if you're not eligible, we'll enroll you in NYC Care. But both of those groups of people, by the way, weren't coming to us before the NYC Care program because they, again, perceived and real, didn't feel like, to your point, they had any access to care. They were calling, they would say there's a 3-month wait. Everybody gives up. But I think what NYC Care did is we improved access. Is it not only built trust in the NYC Care program, but it built trust in us. So I see every patient regardless of insurance status. But many patients may have thought they were going to enroll in the NYC Care program, but potentially even better for them, they're enrolling in health insurance. And whenever that happens, because we have a value-based care arrangement with the insurance plan that we own, we actually, at the end of the year, keep the risk surplus or the amount of money that's saved because we did a good job in primary care so that people didn't get sick enough that they had to go to the emergency department or to get admitted to the hospital. And I'll tell you, without going into the specifics of the numbers here, that's not a de minimis number for us. That's a very substantial number for us. We as the public healthcare system are not surviving now. We've closed our $1.8 billion deficit. We didn't close it by doing more orthopedic surgery. We closed it by doing primary care effectively and embracing the arrangements that existed before, but we were not embracing before.
Bravo.
All right, let's look and see if we've got a couple more of these questions that are coming through. I see David Heckman. You asked a question. Do you want to come off mute? And
David, you have to come off mute.
Hi, Ted. Great to see you again.
You too.
Folks, Ted and I both worked under Dr. Fine about 8-10 years ago at the public health department here in Rhode Island. There are many factors that have to be addressed altogether because, and I've heard all this about workforce this evening. It seems to me a system of your scale, with the public support that you've already gotten, might be particularly well situated to develop collaborations with hospitals, with medical schools, nursing schools, and all of that. What's happening with you guys or anywhere in the country around those kinds of collaborations?
I can certainly start, but I think that there may be others that are more qualified than me to share their deeper experience. Um, at New York City Health and Hospitals, we are part of the Mosaic program, which is a way that we actually target people early on, even as early as high school, to basically be able to offer grant-based opportunities to continue their travels through medical school and to eventually hopefully practice in our system. We think that's a great way to capture really promising New Yorkers earlier so that they can do what they want, which is to be able to stay and help their community through working with us. We also have done a couple of other things, like, for example, one kind of cool thing is we started a nurse practitioner fellowship in primary care. So the nurse practitioners that are graduating, thank you, Michael, from the nurse practitioner programs who don't have any actual on the ground clinical experience in primary care, especially being on their own, gets a mentored opportunity for a 1-year fellowship where they can work alongside me and then they stay. So.
When are you opening your first medical school?
We do have a New York City medical school that's was formerly the Sophie Davis Medical School. It's a terrific,
Great
terrific
medical school.
place. The dean of that medical school refers to it as a national treasure. So I tend to agree.
Thank you guys so much. Margaret, are you there? You had a couple of great questions that I'd love for you to be able to ask Ted directly.
Sure. Hi, Ted.
Hey, Margaret, how's it going?
Great. It's good to see you. Yeah, I actually asked almost the exact same question that Dr. Fine asked, or Michael asked. Suddenly we're all David, Ted, and I, and you're still the director of health, Doctor. About, the fact that you have this public health hospital and health system that's owned by the city that they decided to invest in, and that's kind of key. And most municipalities have gotten out of the business of running hospitals. So I see that as that's a big question, and we've already discussed it a little bit. But sometimes I have a background in oral health, and that's always the question that I ask when I get into rooms like this. Do you provide oral health care? Because it's inordinately expensive to provide.
Yes, we do. We always need more dentists. So what we've done, which goes beyond the NYC Care program, because in New York State, almost all children are eligible for Medicaid. But for children to expand our overall oral health or dental access, which affects everybody, is we've placed dental hygienists in our pediatric practices. So they can actually do a cleaning in the context of your pediatric visit. It doesn't require a dentist to see you, and that also frees up a little bit more access in the dental care side. But much more work needs to be done there.
So that's a model that I worked on in Maine 15 years ago, integrating hygienists. It's a great model. So good luck with that.
We're right behind
and then you can prevent so much of the care and cost that's associated with poor oral health.
Yes, 100% agree. And great to see you.
And actually, Ted, how about physical therapy? Do you think physical therapy is part of the primary care team?
So again, we're lucky, and I use my words carefully there, that being a part of a healthcare system that has 11 hospitals, each of which has a physical therapy department, our access to that is a lot easier and probably better than for others. So in a word, yes, of course I agree with you. And I sort of have an unfair advantage, which is we actually have 11 physical therapy departments. So.
Wow.
That's pretty incredible. Marcus, hi, how are you?
I'm well. How are you?
Good. Did you have a question for Ted?
I did. So Ted, is there a behavioral health component to what you're doing, your work?
Yeah, great question. That was what I was saying at the outset here. We really struggled with how to create the right amount of behavioral health access as we wanted to expand primary care. And I think we've done a variety of things. We actually, in New York City, our public healthcare system, we deliver more than 50% of all behavioral health care in New York City. So we had a robust footprint to begin with, but I think our secret ingredient was our collaborative care model, which, as we define it at least, has social workers that are providing the actual depression and anxiety clinical care face-to-face or televisits with our patients that are over a team of social workers overseen by a single psychiatrist. Then we aren't reliant on finding enough psychiatrists, which I think everybody agrees will never happen. So that's really helped us to expand our mental health access to make all of this possible. Great question.
Well, Ted, I just want to say thank you so much for all of your insights. I'm sure your inbox is going to be flooded in the morning with lots of questions. So
Excellent.
hopefully you'll have some time and space. You're always welcome to join us again. Our next meeting is actually breakout rooms. And so we'll be focusing on, the hyper local playbooks. We're going to be looking at our state playbooks. We're going to be looking at, the social media marketing. So invite friends, invite people. One of my favorite things is what just happened here, which is people saying, oh, hey, we used to work together. This is great. Because it really shows that this is beyond one of us trying to do this on our own, right? This is a group that is coming and linking arms together and saying, let's build this community together. So thank you so much. Thank you to everyone who joined us. Michael, any parting words for us?
Just thanks to everybody for being here. Thanks to Ted for showing us how to get this done. The pathway is pretty clear. The challenge is getting everybody together to do it. I'm hoping we will get people next time from states like Maine, and Vermont and Arizona, where there aren't work groups going yet, to get together to figure out how to get work groups started in their states. And then we want to hear from people in communities all across the country about telling us about that they have gotten together with one person, remembering the power of two, and starting a local work group in their own community. We'll be working on that more together. Thank you all for everything you're doing. And Ted, thanks again. And let's just do more of it.
Thanks so much. It's been an honor to join you.
Have a great night, everyone.
Thank you.